Good morning. The topic what I want to address today is what is the optimal local anesthetic spread pattern. I think it makes a difference to us to know what the optimal spread is, not only to improve success, but also to minimize complications. If we inject in the wrong place, we can cause harm. So I was born in Hong Kong, so I will add my Hong Kong accent to the international symposium. First, I need to let you know I receive equipment support for research from these 4 ultrasound companies. Ben has already talked to you about nerve stimulation, the old days we use it, and the end point is where the needle tip is, and we will seek a certain endpoint for motor response. I think for ultrasound now, we certainly can see the needle. When the needle is placed superficially, we can see where the needle tip is in relationship to the nerve, and also we can see the local anesthetic spread. But what we really don't know at this time is what is the optimal local anesthetic spread. So my first point is not all nerves are the same, not all injections are the same, and not all local anesthetic spreads are the same. I think we need to recognize that. So what I like to do is to address the following. What are the useful local anesthetic spread signs that we can use to help us as we insert the needle? How do we assess local anesthetic spread? How do we scan? Third is what type of local anesthetic spread patterns? Do we always need a circumferential spread when we inject the local anesthetic around the nerve? And how much of the longitudinal spread does it require to produce a good block? And also discuss some of the local anesthetic spread pattern in specific regions of the body. So first, let's look at the spread pattern when the local anesthetic or a fluid bolus is injected when it's not close to the target. So when a needle is inserted, we inject a fluid bolus. And the fluid can be local anesthetic. The fluid, as you heard, D5W is very helpful if you want to use nerve stimulation. The local anesthetic spread in the tissue, it tells you approximately where the needle tip is, whether it's in-plane technique or out-of-plane. But it's not 100% precise because the needle tip can be already a bit deeper than the where you see the tissue spread. So when you see a spread, what I usually do is I take my time to scan a little bit more distally to check for the needle tip. Second, I think the hydrodissection technique is very useful. I see it as a dissection. The surgeons use a knife to dissect. We use fluid, whether it's D5W or local anesthetic, to dissect the tissue plane, open up the space. Now I have created a safe path where the needle can insert. So my technique has changed over the years. Now, when I open up the space with the hydrodissection, then I insert the needle at a time. So I open up, insert, open up, insert. I find that is a very helpful technique. We published this last year just to as a letter to describe how we have changed our practice for supraclavicular block. What is helpful to me is I want to see the needle tip as it goes in. If I don't see it, I use hydrolocation, but also the plexus is here. I want to create the space here. Instead of going right to the inferior trunk, now I go a little bit high up, maybe the middle trunk, open up the space. Once I open up the space, I now have created a pocket of fluid. Now I would change the needle direction and now slowly dissect, and then go down to the inferior trunk. Intuitively, it makes sense to me. I don't want to stick the needle into the end point, the inferior trunk, then inject. So I like to use the hydrodissection method. Also, there are very useful local anesthetic spread signal when it is near to the target. How do you know whether the spread is good or not? So there are good spread and there are also incorrect spread. So in this case, the plexus is here. This is again a supraclavicular brachial plexus region. When I inject, you see the local anesthetic is spreading away from the plexus. So it clearly tells you it's not good enough. So what I need to do now is to advance the needle. When I advance the needle and inject now, it has gone through the sheath. Now I can see that the this area is ballooning up like a balloon. So that tells me now I'm in the right place. So this is the spread is away from the plexus or the nerve, don't accept it. There are many patterns that you see after a local anesthetic injection. This is one pattern that I see for supraclavicular. I show you already. This whole compartment is swollen. So sometimes I worry this may be an intraneural injection, but I think you can see that is one of the trunk. This probably is another one. And what I like to do now is, again, use the fluid to create a pocket. Clearly the needle is not inside the nerve. As I now inject, I can now go further and further to the inferior trunk. So this would be really what I like to do, use the intermittent hydrodissection. We have talked a lot about high injection pressure during the conference. And a lot of people would tell you that if the injection pressure is high, particularly we talk about 25 psi, but in this case someone recommends 15 psi, then, or the patient complain of pain, stop injecting, you should pull back the needle. Okay, I want to add another perspective. This is really based on one group of investigators doing study on dog sciatic nerve, on a number of nerve, and look at the injection pressure. They only put 4 mL of lidocaine with epinephrine using a pump. They find that when the intravascular injection, the pressure is high, 25 psi, the dog suffer neurologic deficit. They insert the needle not with ultrasound, under microscope guidance. Okay, so that is important. What I tell you is intravascular injection can be high pressure, can be low pressure. But with ultrasound, if I get high pressure, it does not every time it means the needle is inside the fascicle. It can mean that the needle is hitting the fascial sheath. In fact, in this case, if you inject, you see the local anesthetic is spreading away from the plexus. You need to actually advance the needle to go through the sheath in order to get to the right target. Otherwise, if you see the fluid is going away from the target and is high pressure, then you need to advance, not to withdraw. So this point we can discuss further during the panel discussion. Why do I say that? I said that is specifically a sciatic nerve of the dog model. What happened to human? I think this case report tells us something. This is neurologic injury after Intraneural injection in the interscalene block in the nerve root level. Okay, it comes out from a reputable center in San Francisco, and I carefully look at the description. The injection was performed with one hand, with an experienced, good-looking, middle-aged attending. And this paper has 2 authors, and Dr. Cohen is not the attending, so you know who the attending is. So I'm sure he did not inject with high pressure. So this still can happen. So don't only look at the dog sciatic nerve model and say that this is the ultimate proof. How do we assess local anesthetic spread? I think we are very comfortable with transverse scan. We always look for this local anesthetic spread pattern. But when I inject now, I just don't stay at one place. I will scan proximally and distally and look at the extent of the spread. So it's very reassuring if you inject in the interscalene region and see it in the supraclavicular area, or you inject in the infraclavicular area and you see the spread in the supraclavicular area. That's very, very helpful. So I scan up and down, leaving the needle in one location. If it's a long nerve, you can go up and down, and you can, not up and down, but you can turn the probe 90 degrees and look at the longitudinal scan. So this is a sciatic nerve, long nerve. You can see fluid above and below the nerve. So very helpful, but this is more challenging. It takes a little bit more time, more practice to do. You can use Dopplers, some of the tools that you have heard about. If you inject, because the Doppler will pick up the flow, you will see this, not just the expansion of the anechoic fluid collection, but a color coming out. Or you can use a little bit of air. It will be very hyperechoic, but make sure you don't inject too much air, otherwise you'll cloud the target afterwards. Or you can use a mixture. Dr. Ganapathy's group have 2 syringes hooked up with on each side, each port of the stopcock, you agitate the saline, then inject. So again, use a color Doppler, you will pick up the flow. I think not every time we can see local anesthetic spread because it's a very dynamic situation. You know and I know after injection very quickly, the local anesthetic will disappear. So you have to check it. And I think trying to look at local anesthetic spread with ultrasound for thoracic paraepithelial block can be quite challenging because you have bony shadows you're not going to see. Or you are now seeing something in such a big individual. So not every time we'll be able to assess local anesthetic spread pattern adequately. So we have talked a lot so far about perineural injection. Local anesthetic injection around the nerve. Is circumferential spread necessary for all types of injections? I don't think we know the answer. There are other types of injections that would also produce a block. If the nerves are next to the artery, we can inject around the artery. Maybe this is safer, it's faster. You don't look for a particular nerve, just inject. Or if the nerve is so small, we heard about TAP block, ilioinguinal iliohypogastric block, is an intermuscular plane block or interfascial plane block. There are also spread patterns that we don't want to see because we can cause injury. I'm not a proponent of intraneural injection, so I would need to know what an intraneural injection looks like, what an intravascular injection looks like, and if you inject in the muscle far away from the nerve target, you probably won't see a block. So this editorial precisely wants to raise the question, what is the optimal local anesthetic spread for different types of block locations? We don't know, so there's a lot more work to be done. Now this is a popliteal sciatic nerve study, okay? So every time I ask, what is the nerve? It's a big nerve with a lot of connective tissue. What's the volume? It's a 30 ml injection volume. And this question we ask is circumferential spread better than non-circumferential spread? So the study design is one is a multi-injection technique, one is a single injection technique, and we find that yes, block success is higher when you do a circumferential multi-injection technique. But when you look at the data more clearly, you realize that there are also circumferential spread for the local injection. If you put the data together, yes, the block success rate is quite high, 80 to 90%. And if you look at non-circumferential spread, the block success is low. So it does tell us that for this particular nerve, a big nerve with such a high volume, circumferential spread is good. When you look at a much smaller nerve, ulnar nerve in the forearm, the injection volume is small. You don't need a lot of volume. This is, again, circumferential spread is very good, but it tells me that probably longitudinal spread, substantial longitudinal spread is not necessary. A small volume for a small nerve, as long as it's injected circumferentially, it will work. Same thing for the interscalene region for nerve roots with a very small volume, 0.9 in this case, 3.6, you get a good block. You get a good block, successful block. The duration of block, we don't know yet, but it works. Again, telling us that you don't need a big volume block for the longitudinal spread. But Dr. Seitz' group challenged and said, maybe we shouldn't get the needle too close to the nerve because we always worry about nerve injury. Is it possible just to get enough close to the nerve roots and then inject, they call it the periplexus block, injection technique just right at the border of the fascial plane between the middle scalene muscle and the nerve root. And by injecting such a big volume, they get a good block. And in our center, a study being done, there are 2-3 investigators in the audience, and we're looking at the needle now. This is 0.84 centimeter away from the nerve, and we still get a block. So perhaps with big volume, as long as the spread of local anesthetic is towards the nerves, immerse the nerves, then we are getting a good block. So intraneural, we talk a lot about swelling. Swelling is a good sign. It's very, very sensitive. Only 1 mil, you will get nerve swelling. It tells you it is intraneural. But now we're getting more sophisticated. We want more than just seeing injections. We are trying to say ultrasound can tell us whether the needle is here, just under the epineurium, or in between, parafascicular or intrafascicular. Again, I don't believe the ultrasound resolution today can tell us that. But you see this, several all investigators talk about intra-epineurial injection. They look at nerve swelling, and this one is even more interesting, subepineural. They feel that they can the needle just pass the epineurium. When they inject, they do not see any swelling. They feel that this is just under. So it's intraneural, but just past the epineurium. I'm not so sure at this time I can tell by ultrasound this is what's happening. I would like to see histological data to substantiate it. Then perivascular. Perivascular injection will work in certain circumstances. For infraclavicular block, when you see the cords very close to the artery, it works well. We know that if the spread is posterior to the artery, it works well, but when it's anterior to the artery, it does not work well. And this is what the authors recommend is a U-shaped spread. You will get all three cords. Now what happened? This is strange. Where is my... Okay, very strange. Okay, this makes sense when the arm is on the side, when the cords are farther away, because oftentimes the medial cord is here. But one trick is you have the arm abducted at 90 degrees, you bring all the cords together, then maybe you don't really need this U-shaped spread anymore. You can do an injection here. You have stretched the plexus and bring everything together. A recent study looked at perivascular injection in the axillary region, whether it's just one at the 6 o'clock, at 12 and 6 o'clock versus all these three. They find there is no difference. The onset is as quick, sensory motor block, no difference. Now, I have tried perivascular technique in axillary region. In my hand, it does not work as well as the success rate is not as high as perivascular. That's why I don't do it. But you have to decide what is best in your case. And they talk about this silhouette sign with the fluid right next to the artery and obliterate the arterial wall image. So intravascular injection, we talk a lot about it would cause local anesthetic systemic toxicity, and it's important to remember, do not only look at the injection in the beginning of the case of the injection, you should look at it throughout the injection because your needle may have moved during. So what I really want to see is this hypoechoic fluid collection next to the nerve. If I see the fluid expansion like this, I know this cannot be intravascular. This is intra-arterial. I don't know why we would need to see that because oftentimes you see blood coming back. But if you do see it, it will be a blush of a turbulence like this when you see that. There are limitations. Again, ultrasound scanning for somewhere that is deep can be a difficult part. This is cardiac arrest after a parasacral block, so obviously the operator did not see the local anesthetic spread well. Okay. So we talk a lot of TAP block. I'm not going to say much, but this will be an intermuscular block. We know that these are the thoracolumbar trunks coming anteriorly. I still don't believe that the original ultrasound-guided technique is optimal. We put the probe like this, transverse inject. We are very happy when we see the spread. But where are the nerves? The nerves are here that we want to block. So we want a careful-caudate spread. But if we only see a spread horizontally, we only are blocking a very small part of the anterior abdominal wall. So I think that what we need to look for the local anesthetic spread is careful and caudate, not just looking transverse. So this is the reason I think we come up with this new technique, the 4-point approach, 2 on each side in order to get to block the midline incision. So 2, 1 medial, 1 more lateral in order to block the complete tap block completely on each side. Right? And same thing for ileoinguinal hypogastric block. Remember, we think that we need to be very precise in this compartment between the transversus abdominis muscle and the internal oblique. That's true. Successful block if it's correct placement. But look over here too. When the needle and the injection is the transverse abdominis muscle and also the internal oblique muscle is not always fail. Just like when the surgeon, when they do the infiltration, they go in and out without ultrasound, they still get a good block because some intramuscular injection close enough to the nerve will also work. So you can apply the same technique for obturator nerve. Just put it between the adductor, two adductor muscle, longus and brevis, and you can get a block. So you don't have to target the nerve, but inject in the right plane. So in summary, I think there are many local anesthetic spread signals. Hydrolocation tell you where the needle tip is as a surrogate indirect marker. The dissection will help you to create a clean path for the needle to go in. Use the transverse scan, but don't forget the longitudinal scan when it is a long nerve. The different types of local anesthetic spread pattern, it can be around the nerve, but there are also, if the nerves are close to the vessels, it can be a perivascular technique, or if you don't see the nerve at all, it will be an intermuscular technique. Maybe circumferential spread is not necessary all types of injections. We don't have all the answers. And maybe particularly for small nerve, extensive longitudinal spread may not be necessary. And I think we need a lot more study to look at other areas, for example, the proximal sciatic nerve area. Thank you very much for your attention.